Welcome, everyone. My name is Mohammed Hamid Zaman. I'm a professor of biomedical engineering and director of the Center on Forced Displacement at Boston University. And along with our colleagues and partners at the AMR Policy Accelerator and the Global Strategy Lab, we are absolutely delighted to welcome you all on a topic that is both important and unfortunately understudied. On this World Refugee Day, we are going to talk about antimicrobial resistance, an important but underappreciated challenge among migrants that includes, of course, refugees, but also internally displaced communities and stateless persons. With me are four colleagues who are going to talk, three colleagues who are going to talk about different dimensions of the problem. I will introduce them and then they'll talk about themselves. We will have some questions that we've already prepared, but after that, we would love if you can also engage with us. We also have technical support on the background that can help us navigate through that. Just a couple of housekeeping things. We want to make sure that the questions are rich and honest, but also certainly with respect and in a way that allows people to share their experiences without any concerns or anxieties. Also, if you wouldn't mind filling out a survey that you will be getting soon after the webinar has ended about how it went, what are the things that we can work on, and things like that, that would be great. I want to mention that we have two colleagues who are joining us from outside the United States and Canada. I appreciate the fact that many of you and two of our participants are on time zones beyond the 9 to 5 time. So I really appreciate that. Any of us may have technical issues regardless of where we are. So I hope you'll bear with us if there are video or audio challenges. So let me first introduce myself. As I mentioned, I am a professor of biomedical engineering and also the director of a center at the university known as Center on Forced Displacement that brings together scholars, practitioners, researchers, and professionals from all over campus and beyond to understand, investigate, appreciate, and think about complex challenges facing forcibly displaced communities. That includes people who are refugees and cross international borders, internally displaced persons, as well as stateless communities. Our researchers come from humanities and social sciences, sciences and engineering, public health, and law, and work together on some of these challenges. Today's event on the World Refugee Day is an example of that. And as we will see that there are colleagues who come from different disciplines through this work. We are very interested in hearing from you and also not only about the challenges that you face, but also possibly solutions on what needs to be done. I'm also reminded that today's conversation is happening at the heels of an absolutely disastrous tragedy in near the coast of Greece a couple of days ago, where hundreds of people died, including many from my home country of Pakistan and where Dr. Shobha is as well. That challenge reminds us of the complexity of the problem and the necessity of the work that all of us need to do to protect the vulnerable people in all parts of the world. With that, I will ask our esteemed panelists to introduce themselves. I'll start first with Dr. Susan Rogers Van Ketwick, who is at the AMR Policy Accelerator. Susan.
Hi, everyone. Thank you all for joining us today and for the warm introduction. My name is Susan. I am the Managing Director for the AMR Policy Accelerator at the Global Strategy Lab at York University in Toronto. And our goal at the AMR Policy Accelerator is to really support governments and international organizations in addressing the policy side of antimicrobial resistance, helping countries to build their first national action plans or revise their national action plans and bring that evidence-based lens to all of the work that they're doing so that we can really tackle antimicrobial resistance head on and ensure that we have a world with sustainable antimicrobial use for everyone.
Thank you so much, Susan. Next is Dr. Shobha Lakshmi, who's joining us from Karachi.
Hello. So thank you for inviting on this important issue. And AMR in IDPs and refugees actually require multifaceted approach. It's a multi-pronged approach is required because multiple issues has to be addressed. It's not just one problem. There are there are a couple of problems that if we really want to tackle this issue, I mean, a strategy is required for their continuous rehabilitation and improving the infrastructure and the facilities which are not available. So,
Thank you so much.
Sorry.
No, do you want to introduce yourself, Dr. Lakshmi, where you work, your own area of expertise?
Yes, so my name is Dr. Shobha Lakshmi. I am Assistant Professor Infectious Diseases at the National Institute of Cardiovascular Diseases in Karachi, Pakistan. And I am also active member and office bearer of Medical Microbiology and Infectious Disease Society of Pakistan. And through that forum, I'm involved in a couple of trainings regarding infection control, antimicrobial stewardship, and antimicrobial resistance. And I work closely with migrated population in natural disasters, and I held three health camps in Karachi and in interior of Sindh, which was affected in 2022 floods.
Thank you very much, Dr. Lakshmi. Then on to Nela Gross, who's a graduate student at Boston University, but joining us from Nairobi. Nela, please introduce yourself.
Okay, hi, thank you for the introduction. My name is Nela. I am a PhD candidate in Dr. Zaman's lab, where most of our research focuses on antimicrobial resistance within different low and middle income countries. My work specifically revolves around how different environmental factors will impact antimicrobial resistance and how that might happen in different populations around the world.
Thank you so much, Nela. Just to give everybody kind of a map of how things are going to go, I'll ask questions one at a time in this order. First Susan, then Shobha, then Nela. And then in the meantime, if you have any comments, and this is for our colleagues who are joining us, please do write in the chat. We will continue to look at the questions and ask them if there's any clarification. But after sort of 2 rounds of questions, we'll open it up for colleagues who join and to ask questions directly. But if you are sort of wondering about something or have a clarification question, please do type it, and we will make sure that be incorporated. So let me start with you, Susan. Antimicrobial resistance, or AMR, and forced displacement are 2 complex challenges, 2 very important challenges. Unfortunately, they're rarely talked together. Why do we need to think about the convergence of these 2 issues?
So you're right. These are 2 incredibly complex global issues. And I want to start actually by just describing what antimicrobial resistance is before we get too far into this webinar. Antimicrobial resistance occurs when pathogens, the bacteria, the viruses, the fungi, and the parasites that can cause infections change over time so that the medications that we use to treat those infections no longer work. And that will really increase the risk of disease spread, severe illness, and in many cases also death around the world. And that's a really insidious challenge because resistance has the potential to impact with so many different areas of our lives and of our livelihoods, not just health outcomes, but economic outcomes and things like that as well. And what we know about antimicrobial resistance is that the most serious consequences of that are likely to fall on people who are already in vulnerable and precarious situations. And so we know that the conditions under which refugees and migrants often leave their countries of origin and travel to another country can lead to increased infections, can lead to disruptions and barriers in terms of accessing healthcare. It can lead to crowding. And all of those different things are risk factors for getting an infection that could either be very serious or potentially lead to death. And so recognizing that refugees and forcibly displaced people have these special needs and requirements in terms of their health and in all of these barriers to accessing healthcare makes it really important for us to actually talk about these 2 challenges together, to take a really close look at what those barriers are and how we can make sure that all of those consequences of antimicrobial resistance aren't really concentrating on top of all of the other challenges that forcibly displaced people are already facing.
Thank you very much. Dr. Lakshmi, let me sort of turn over to you. You work at the front lines with displaced persons in Pakistan in the aftermath of the 2022 floods. What were the challenges, some of the challenges that you saw firsthand related to antimicrobial resistance?
So there were a couple of factors. Poor housing. I mean, they were living in makeshift camps, so crowded. So if someone having an airborne disease like or measles or tuberculosis, because tuberculosis is really endemic in this part of the world, because of this overcrowding and these outbreaks, or even because the drug-resistant infections are really common in this part of the world. So people are actually carriers of resistant organisms like the E. coli in this part of the world is actually resistant to many antibiotics. It is multi-drug resistant. So typhoid is another challenge in this part of the world. Here people have typhoid, Salmonella typhi, which is resistant to ceftriaxone and cephalosporin and only sensitive to carbapenems. Then because of overcrowding, because of poor sanitation, someone who is infected can transmit this infection to another person who is not infected. Then sanitation was really bad. Then these people, actually the floods affected rural areas. And the majority of the people in the rural areas of Pakistan actually live. I mean, this is a sad fact, but in our part of the world, these people actually live below the poverty line. So their baseline nutritional status is also really very bad. So they are at more risk of acquiring the infections because they do not have the ability. They're already malnourished. Their hygiene practices are not good. Then now they come into an overcrowded place where they're living in close quarters in camps, sleeping under the no water available. The water condition before the floods were bad, but now there's no water available for sanitation, no water available for hand washing, no water available for daily routine things. So the problem is compounded. Then poor accessibility to the healthcare facilities. As a doctor, we are a group of doctors. We went there for camps, but we had no diagnostic test available there. So we just took a simple antibiotics and anti-malaria. And anybody who would come us with fever, because we had no antibiotic test available, and the nearest healthcare facility was like 3 to 4 at the distance of 4 or 5 hours, and there were no transport network available, we would giving them empirical antibiotics or empirical anti-malarials. So all these facts actually compounded the already existent antimicrobial resistance, which is already one of the highest in the world. It has actually, I think, post-flood, post this period, the problem has increased. And that's what I'm saying, that this problem needs a multifaceted, multi-pronged approach. It's not just one problem. There are a couple of problems that has to be solved to tackle this problem.
Thank you so much, Dr. Lakshmi. We already have a question. I'll ask our colleagues to just wait on the solution aspect, and I'll pose it to Dr. Lakshmi and Susan in due course about going from sort of an analysis or documentation of the problem to the solution space and what needs to be done. We'll come to that in a second, but the question is very relevant. Let me turn over to you, Naila. So forcibly displaced persons often live in complex but also polluted environments. How does that impact the likelihood of development of drug-resistant infections?
Yeah, so I think it was mentioned before that antimicrobial resistance happens when, there's a selective pressure on the bacteria. And so it's actually been shown that most refugees, around 3/4, live outside of the refugee camps in urban environments where things like wastewater treatment is not common. And so looking at environmental factors such as heavy metals, microplastics, or even laundry detergent will sort of start these selective pressures on the bacteria and force them to have this resistance much faster. And that's also what our lab does, is we look at different environmental factors, and it's sort of a, as Dr. Shoba was saying, a multifaceted problem where, you know, maybe you wouldn't think that microplastics would be an issue, or laundry detergent going in your wastewater, but they do in fact impact the development of drug resistance very much so. And so, yeah.
Thank you so much. So let me go back to Susan with another question. As someone who works on AMR policy at the global level, what are some of the ways in which you think we can prioritize the issue of antimicrobial resistance challenges faced by forcibly displaced communities? What are some of the things in which we can generate awareness, we can increase funding, we can prioritize policy? What do you think?
All of those are very important things, and calling attention to the issues, I think, is going to be one of the key aspects of that. One of the first things we can do is put an emphasis on that strengthening of basic infrastructure. Dr. Luxmi has already called attention to the importance of clean water. Nail has mentioned the lack of wastewater treatment, and those things are key because preventing infections is going to go a lot further than just reacting to infections when they've already developed. And that means we need this integrated approach. We can't think about AMR over here as one bubble with one pot of funding, and clean water and hygiene and sanitation issues over here as a separate issue, and disaster management is a third issue off to the side. We need to think about an approach that actually integrates all of those different things together. The second thing that we can do is really bring a focus to the barriers that forcibly displaced communities face when they are just trying to access antimicrobials and healthcare. So our team at the AMR Policy Accelerator, the Global Strategy Lab, did a review last year with the World Health Organization on access to antibiotics among refugee and migrant populations. And we identified a whole host of barriers that people face. Some of those barriers were personal, like language barriers, fear of deportation, stigma around particular infections. Some of those barriers were logistical, like lack of transportation to reach clinics and long wait times at clinics. And then some of those barriers were really systemic. It was high costs related to lack of health insurance, or not having an access point to the healthcare system, not having sick leave to attend clinics and things like that. And what we learned was that when people come up against those kinds of barriers, it often pushes them out of a formal healthcare system and into a more informal system where they're likely to access antibiotics that are not quality controlled, may not be what they actually say they are, might not be the right antibiotic for the condition that they have at the time, might not be the right treatment. And all of those things can also help drive antimicrobial resistance, as well as, you know, decreasing the quality of care that forcibly displaced people are accessing. So if we can try and address those systemic barriers to accessing antibiotics through education, through programming, through structural changes, it will really help ensure that people are actually accessing that quality level of care. And that means working with governments to overcome national level barriers. And it also means working with all of the different international organizations that are part of water, hygiene and sanitation, antimicrobial resistance, antimicrobial use in other sectors, and bringing them all together for stronger global governance arrangements that recognize that particular vulnerable communities have these specific needs that we need to actually address in a concerted way. Oh, I think you are muted.
Sorry, our colleagues in the background, if you could put the link for the report that Susan just mentioned, that would be great, because I think it's a rich report that I personally have learned from and benefited from. And I think many of our colleagues may find that useful as well. So if they could just sort of put that, that would be great. I see that the number of questions are coming. Please continue to come. I'll try to incorporate all of them as well. Some of them are being addressed, but we'll bring them to the fore anyway as well. Dr. Lakshmi, over to you with a sort of a slightly different question. AMR, and as you know very, very well, has to be viewed within the broader context of healthcare. broader context of infection cannot be viewed in a silo independently. From your experience, what are some of the main drivers of infection among the displaced persons that you saw after the floods in Sindh last year? And what are some of the specific solutions that we should think about that may be practical?
Okay. So problems that I have discussed: poor baseline nutritional status, poor access to healthcare facilities. They are already colonized with drug-resistant organisms, because people in that part of the world do not even have access to doctors and healthcare providers in this, even in this era, and they go to the a store, and in Pakistan, sorry to say it, but over-the-counter and medications. And the medications which are substandard are available at the stores like the grocery stores. And people just go there if they've got throat or fever. They take 1 dose of antibiotic, they take it, or 2 doses, they get better, and they stop taking it. And sometimes, even if the doctors prescribe it, they do 2 doses and they stop taking it because they cannot afford the medication. So this actually contributes to the problem. So the underlying levels of resistance are really high because of these multi problems: poverty, poor access to sanitation, poor access to quality healthcare, poor access to quality drugs, availability of over-the-counter antibiotics and the substandard drugs. And people, because the poverty is there, people cannot afford the healthcare is not. People do not get, of course, there is a system of dispensaries and healthcare units, but people do not get medications from there. They just go to a local store, get a dose, 1 or 2, even for viral infections, they take antibiotics. So they are already colonized, and these genes are harboring regions. Then poor sanitation, mixing of sewage and local water lines. So they get colonized with these resistance genes. So the solutions is, as Susan said, that solution is you cannot get solution by just one approach. And the problem has been there for years. It just came to surface of the floods, and the population was displaced. And years of planning. 5 years, 10 years, one short-term, long-term planning is required. And it's not just, if you want to spread resistance, you have to educate these people about good hygiene. When we educate these people about good hygiene and not to use antibiotics on their own, then we have to provide them with sanitation, and water for their personal hygiene, good quality water for their use. Then we have to build an approach to provide this population with healthcare, which is not available. Even in that part of the world, an unqualified person, a person who is not qualified, a healthcare worker, gives them, because that is cheap and the quality healthcare is expensive, they usually go to that person, someone whom they trust and who's not even a qualified healthcare professional and a prescriber. They go there and that person gives them 1 or 2 doses of antibiotic. So a rehabilitation kind of approach is required, where you have to lift them up and develop, and financially, education, good housing, good sanitation, water, nourishment, because these are poorly nourished people. So good nourishment. So if you ask me solutions, my mind gets confused that how can we solve this AMR problem by not addressing those problems, because there is no such short-term solution. This has been there for 70 years. These people were deprived of these basic necessities, and we really need to do something for them. But then now another thing is that political instability and the economy has gone further down post-floods. So the problem has compounded. Now these people, they have gone to their areas, but they are like literally sleeping in this summer only under the sky, no hygiene, no water, no food, nothing. They get sick, they have no access to healthcare. And this is what I've told you, that the terms of right drug, antimicrobial stewardship, right dose, right diagnosis is a kind of a dream which cannot be achieved right now. This is we are not thinking about it. Just uplifting them and providing them with the basic healthcare units, basic healthcare facility where the rapid diagnostic test, point of care testing is available, and just access. Actually stopping access to over-the-counter drugs may be a solution, but I don't know the solution. The problem is such a huge problem, such a big problem that mind gets crowded when you actually start thinking about the solutions, on most of solutions.
Thank you so much, Dr. Lakshmi. You pointed out a few things that I want to sort of pick up and highlight before I go to Neela for the question. First of all, the complexity of the problem requires all of us to come to the table. That means engineers and scientists, that means social scientists and economists, that means political scientists and law scholars. I think that is something that we certainly want to initiate through these conversations. And we see people here who come from different disciplines, epidemiologists, infectious diseases, somebody who is a scientist and an engineer in material sciences, and also really looking at this problem from a social justice lens, but also from a legal lens, from a public health lens. And I hope that this conversation that we're starting today is not the end and only happens on World Refugee Day, so. But certainly goes beyond. But your point are very well taken. Neela, let me turn to you for something on the other end of the spectrum, and that is basic science research, right? So we've heard about public health, we've heard about clinical work. Your work has sort of touches on the basic science side of things. So my question to you is, you're working at the interface of the lab and the field. Why should we emphasize fundamental research to better understand AMR among forcibly displaced communities?
Yeah, so that's a really good question. And I think one important thing to point out is that a lot of people want to put a stopper in or find some cure that can immediately be put in the clinic, but it's really, really important to understand the fundamentals. So in order to address the problem, I think it's really important that we have to start at the basics. And as I mentioned earlier, there's so many different types of environments that people live in. The different types of heavy metals and microplastics and other things that affect antimicrobial resistance differ throughout all the different environments, and even temperature-wise, and whether it's the rainy or the dry season. So in order to understand what is affecting antimicrobial resistance and how much of an effect it has, we have to look at different variables individually. And so in the lab, I know we've done a lot of good work on zinc and iron individually and seen those effects. Personally, I work with microplastics and how that affects antimicrobial resistance. And so in order to sort of gain this understanding of how these different communities are affected, it's important to, as I mentioned, to understand each individual variable, and so that we can have sort of a holistic approach once we figure out what the environment these people are living in, and how they're being affected based on the different levels of variables that are in their environment. So yeah, it's incredibly important that we understand the basics of what's going on if we want to address the problem upstream rather than putting a stopper in it when it happens.
Thank you so much, Neela. I already have a list of questions and I'll try to go through them. I might combine some of those in the interest of time. And they're sort of really fantastic questions. Some of those are exactly the kinds of things that we ought to be thinking about. Let me start with the first one from Muhammad Yar Subhan Qadir that starts with AMR stewardship is almost always compromised in displaced communities due to a variety of reasons. What can be a suitable solution towards AMR stewardship in these displaced environments for the migrants? Let me start with you, Susan, and then I'll ask Dr. Lakshmi to comment on that as well.
Absolutely. Sorry. I think that antimicrobial stewardship in these cases is a really interesting challenge. One of the things that we found in that report that we wrote last year was that in some cases, refugee populations are likely to be overprescribed antimicrobials by healthcare providers. Because there is a sense among healthcare providers that they may never see that patient again. And so the safe course of action is, in their minds, not to wait for a test result or something like that that would confirm an infection, but just to give antibiotics while they have the patient in the room and have that access to them. And I think that's a very logical approach from a healthcare provider point of view when you're working with populations that may be very transient like that. I think that what that kind of compels us to think about is how to provide more tools to healthcare providers. Things like point of care, rapid diagnostics that might allow you to get a diagnosis very quickly so that you could target that antimicrobial, get the right antimicrobial for the particular infection that the patient has in real time. I think that it's important to remember that good antimicrobial stewardship practices should kind of still apply in an emergency situation. You don't want to just be handing out antimicrobials just because. But I recognize as well that the rules may sometimes change about what is a good use of an antimicrobial when you don't know whether or not you'll get that patient back again to be able to give them a solid diagnosis.
Dr. Lakshmi, I'm going to combine a couple of questions that have come up. One is antimicrobial stewardship, and the other one that I think is really interesting is where does the responsibility lie, and how do we motivate or how do we, let's say, incentivize policymakers, government to pay attention to these matters, right? You mentioned that this is not a failure that happened in 2022. It's a failure that has happened over decades. And one thing I want to emphasize here is that these emergencies are often what occupies our mind, but there are many refugees who've been there for 70 years. The Palestinian refugees since mid-1940s, the refugees in northern Uganda since early 2000s, in the Kenyan camps since mid-1990s. So these are long-term things as well. So how do we sort of think about that, and how should we incentivize the local governments to prioritize this?
So there has always been funding available, but it's not accountability is required. I mean, policies are there, funding is available. What happens that in the initial phase of emergency, everybody is active and the policies are made, but the solutions are always short term. So the solutions should be there for long term, should be made. The policy makers should take into context the background of these problems. Then also the solution, if the policy makers suggest something, they should make it a long-term policy. Then that accountability is required. Accountability on the part that where the funds come, they go to the right organizations who are actually doing the right thing, the right justification. If they use funds, if they should provide justification where funds are used. Use education and capacity building. I mean, the donor agencies or the policy makers, they do provide the policy. But what happens that education and capacity building is not there. So even in Pakistan, we get the funds, the policies are made, but not much is spent on capacity building. Until and unless the local population, the population which is residing there, these refugees or the people there, or the people who are actually living there, if the capacity is not built, the capacity is not created, they are not given education, if they are not empowered, you cannot find the long-term solution. Because what happens that the policies are made for a time period. I mean, a government comes or a funding agency gives just for a short time. This needs long-term solution. And that can only be possible if the people are taking from that population. There are people who are part of that population. They are trained, they are empowered, and then they are made to help their people. Then only a solution will come. Until and unless you do not educate those people, you do not build capacity of those people, if we do not educate those people, nobody from outside will come and help them. Right? So we have to choose people from that population who is displaced. They know their problems, they are aware. You take the people from there, you empower them, you train them, you actually build them, and then empower them to develop programs, to develop policy for their people, because they are actually the ones who are suffering, and they are the ones who are actually have the first-hand idea of what is happening. External factors, externally you can just provide support, but externally no one can come to solve this problem. No, this never happens in the world. I mean, I am living in Pakistan and I did my training and then I came back to Pakistan. But living in Pakistan, I know the problems here. So if I am made capable, I know the problem, I'm going to stay here, then only I will be able to solve this problem. A person from outside cannot help, they can help in capacity building, they can help in training, but until and unless the local population is not empowered, is not taking, when their point of view is not taken when the policies are made, no solution can come. Long-term solution cannot arise. So this is my 2 cents. And
Thank you so much. Neela, one of the questions that was asked earlier, and this has been other colleagues as well, that I think is an important one, and that is about the evidence and data. So let me start with Hugh. What specific evidence gaps should we work on when we are researching? What would be good data that will allow you to be successful in your work? And then I'll ask Susan the same thing as well. What data can come from the ground for you to think about policies and the policy angle? Let me start with you, Neela, first.
Yeah, so I think one thing that is invaluable to us would be field work and field measurements that we can sort of validate our findings with. It's one thing to do something in the lab, but it's another thing to actually apply it out in the field. And so being able to take measurements of these different environmental factors to see if they are indeed affecting the antimicrobial resistance in the actual environment is really helpful, as well as sort of just finding the holistic understanding of what the lives are like of the people who are suffering from antimicrobial resistance would give us an even better understanding of things that we should be looking at. As I mentioned, heavy metals, microplastics, soap, detergent, they're not really the same at all. And so finding, as you mentioned earlier, people who have different perspectives, who can find different factors to look at, to look in the lab and then potentially sort of mitigate out in the field is incredibly valuable to anyone who's doing research in the lab, I think.
Same thing to you, Susan. Think about what would be data that allows you to think about these questions, think about the impact, to be able to make better, sharper, more focused policy recommendations. What would you like to see?
Absolutely. There's an old saying that what gets counted counts. And that is very, very true when we think about trying to drive evidence-informed policy. Typically, what we are relying on is some sort of surveillance system that is keeping track of the scale of the challenge, both in terms of infection rates and drug resistance rates, and also in terms of access to antimicrobials and how many antimicrobials are being used. In those systems all over the world, they are it's very, very rare to find that data is disaggregated and actually takes a look at vulnerable populations. In fact, it's very, very rare you even see something as basic as a gender disaggregation to tell you about whether the infections are disproportionately affecting men or women in a particular situation. And without that kind of data, without being able to zoom in and say, okay, this is what the situation looks like for marginalized populations, or this is what the situation looks like for marginalized women, particularly, you don't have the evidence to build a program that you think is going to be able to work. And so being able to use new technologies that we have, things like wastewater surveillance and cell phones and all sorts of different things to be able to actually capture data in a way that is robust, that we know that the surveillance system isn't just picking up this like thin sliver of people with infections in tertiary care hospitals, but rather is actually capturing the bulk of antimicrobial resistance so that we can find those challenges and then develop policy that addresses those challenges is really, really essential. And then beyond that, I think evaluation studies are really important. We can put programs into place that address problems that we think exist, but if we're not evaluating how those programs are rolling out, we have no idea whether we're actually having the intended impact, whether we're actually making people's access to antimicrobials better or not for forcibly displaced people or in emergency situations or wherever else. So getting that kind of data really helps us actually drive quality improvement in those programs.
Great. I'm going to combine several questions that have came in the last few minutes. One is the fact that in many countries, refugees are formally denied healthcare. The question that Romina asked was about TB, right? So national TB programs would exclude refugees, or we saw in other places, refugees were at the bottom of the list when it came to COVID vaccination. Some countries did very, very well, for example, Jordan. And then again, what we want to do is recognize that this is not just about refugees. This is also about stateless people. The ethnic Bengalis in Pakistan is one example, and many other sort of scenarios as well. So I want to sort of ask Dr. Shobha this question of formal exclusion, and how do we sort of get people to recognize the tragedy that is associated with this, and how do we sort of build on the momentum to change the course there? What do you think?
So we have mentioned policy. The policy makers should take this population also when they make policy in context. Also, surveillance. We have no surveillance data. How much these problems exist in the refugee population. So when we have these surveillance data, the background data, then we can influence the policy makers also to take this population into this. When they make policies, this population who has limited access to these tests and these healthcare facilities. So a widespread awareness is required, and also surveillance, a background surveillance data that how much this population is affected, and then making policies, making campaigns to help that population, and to not to just outcast them and just leave them and just and demarginalize them. So it also sensitivity on the part of the government is required, because usually these campaigns are government run, so they should also look into. But the problem is that in a country like these countries, where like third world country, the data is very, very poor. So there is no authentic data or surveillance data is available. So when the policymakers make policies, they do not have the exact numbers because there's no data. And no numbers are. I mean, people here, there are refugees who are even in Pakistan and other African countries, the people have refugee status for decades and their population has increased. But if data is not available, there's no numbers available, how can we just make policy or a strategy to help them? So surveillance data is required. And then when the numbers is available, of course, when the strategy is met, this population will be taken care of.
Great. Another question, again, combining two questions together. One is about the drivers of resistance, but the question that came along was climate change being one of the drivers, right? So increasingly, we are seeing people migrating because of climate. Some of my work in West Africa, in the Sahel region, is seeing sort of this combination of climate. They are affected by increased insecurity that sort of reinforces each other. And so climate and conflict sometimes reinforce each other in one way or the other. And we are seeing that in Yemen with internally displaced persons. We are seeing that in West Africa. And of course, some of the aspects of what Dr. Lakshmi talked about were driven by sort of climate change, also, of course, local policies. How do we think about the drivers, and should attention be paid to the driver's side as well, and not just on the treatment side, right? Are we also thinking about it in a way that is not going to address the challenges? What do you think, Susan?
We, for a long, long time, have really looked at antimicrobial resistance as if it were just a medical challenge that could just be easily navigated by, through the interaction between a provider and a patient. And I think what is increasingly clear is that AMR can't just be limited to that small medical sphere. We know that there are these broader global drivers of antimicrobial resistance, and that resistance is going to impact not only lives, livelihoods, all sorts of different things. And so I think the challenge for us now is really to convince policymakers and those with authority to recognize that when we're talking about antimicrobial resistance, we're not talking about just a simple sort of challenge that happens within the confines of a hospital. We are talking about all of these drivers like climate change and everything else that really have the potential to reshape healthcare, reshape economies, reshape the way that we live our lives. And I think that it's a challenge to make that clear, but I think some of these climate examples and things like this are going to really help us reinforce that. It's not simply that we can think about AMR as confined to hospitals. We have to think about, as climate change forces people out of their homes, forces people out of their communities, that is going to also increase antimicrobial resistance. It's going to increase the spread of infections. We have to build healthcare systems that are ready to deal with those challenges. And that is not going to be a challenge that is limited to folks in the global south. That is going to be a very rude awakening to many, many folks in the global north as well.
Great. I'll take one more question. We are sort of reaching the top of the hour, and I recognize it's already late in many parts of the world. So I'm going to take again a question, then sort of try to combine these two, and that is sort of both the global level of engagement, the UN organizations, ICRCs, and others, as well as engagement with the local communities and the local groups, people who are actually at the front lines. How do we sort of make that connection? So let me start with you, Dr. Lakshmi, about sort of this question of sort of these large international organizations with a significant mandate in many countries in their purview, and somebody who is actually working in the community and ideally even from the community.
Yes, so nowadays making connection is not difficult in the era of internet. You can just approach them and talk to them and listen to their problems. And I told you that these people need education. I mean, there are a couple of bright people there. It's just they do not know how to approach the international organizations. It's just they do not know how to approach those resources. So it's just that empower them, educate them first, and then empower them, make connections, teach them, and they will do wonders. This is how, it's only that, it's just that international organizations actually already approach governments. But to be honest, in these lower middle income countries, the governments, they take it as a genre, but majority of these LMIC, the governments itself, the people at the top are corrupt. So the organizations approach the government, the funding is released, the policies are made, but they just remain on the table and not reach that population. The best is that the people from those organizations should visit those areas, identify people, and that in those areas, educate them, treat them, empower them. And then only the difference will occur. I mean, we can expect a difference. Otherwise, all these exercise, what has been running for decades and decades, is not creating any difference in majority of the world. As far as LMICs are concerned, it does not reach to the population that for which that is meant and to reach. So that population is living a very miserable life for decades, no matter how much effort is made.
Thank you very much. I want to end now and sort of give people a chance to sort of regroup for their next meetings as well. I am left my email as well as that of the center, and I'll ask our colleagues from Canada also to sort of enter their contact information should they choose to do so. We hope that this is the beginning of a conversation that brings together scholars, practitioners, researchers, community workers, and activists, people who are on the ground, people who are looking at this from a historical lens, people are looking at it from a predictive lens, basic scientists and applied researchers. We hope that this conversation continues in different spheres. We recognize that the expertise that we bring in today is a limited expertise. People have extensive experiences, and we hope that they will be able to share that with us and give us the opportunity to learn from them. We also want to make sure that we do not think that the knowledge here is sort of limited in the global north, or it resides only in a particular country or a particular community. I think this is absolutely important. And we also want to make sure that the voices of those who are often silenced through politics, through exclusion, through racism, or other reasons of discrimination are brought to the fore. None of this work would be meaningful or would have any moral standing if we are unable to listen to them, to engage with them, and to really think deeply about our own biases as well. So with that, I want to thank everyone, our three esteemed colleagues, Susan, Shobha, and Neela, as well as many people on the background who made it possible. This took some time to develop, and people at the Global Strategy Lab, the AMR Policy Accelerator, did a fantastic job in making this happen at such short notice. And for that, I take full responsibility that I was not on top of things as I should have been. So, but despite that, I think the team was just absolutely fantastic in working around that. So with that, I will thank everyone and hope that you have a wonderful rest of the day. Thank you, Shobha, Susan, and Neil.
Thank you.